Your life.
All right. Very good evening and good morning and good afternoon to some of the people who are joining from all parts of the world. Very happy to introduce this initiative from All India Ophthalmic Society. The International Masterclass learns from the world's best. And today, on Saturday, April 27, 2024, we are going to have one of the world's best in the pediatric cataract. It's my pleasure to introduce my friend and mentor, Dr. Ken Nischel. Ken Nischel has several hats, and also he has traveled around the world. Why this traveling around the world is important? Because it's very important to understand each country, how we deliver care for children or even in adults. You need to understand with the limited resources, how can you give the best of the best care for our children? And in those, pediatric cataract becomes a very important disease. I will tell you why it is important probably after his lecture, because you need to know what are your resources to give the best for the child. Dr. Ken Nischel, I know him for more than a decade now, almost 1.5 decades. He is born in Africa, Kenya, Nairobi, and all his education happened in United Kingdom. As you can see here, the residency in the King's College, and then he went to Toronto to do his pediatric ophthalmology fellowship in Hospital for Children at Toronto. And then he returned and became an attending and the director of pediatric ophthalmology at Great Ormond Street Hospital for Children. Again, he was there for a decade before he returned, or probably he relocated to US, where he is there for more than almost close to 14 years now at University of Pittsburgh. And he is the chief of the Division of Pediatric Ophthalmology and Strabismus. Some of the things he likes to teach, that's his passion. And as any academic pediatric ophthalmologist, his contribution to pediatric ophthalmology is immense. That's why he is one of the world's best. His specific area of interest in research and translational clinical care is pediatric corneal transplant, pediatric glaucoma, pediatric anterior segment developmental anomalies. Accordingly, he has published very widely in this field. And on the leadership position, he has multiple hats. You can see on the slide here, he is a medical director for digital health. And also he is assistant medical director for UPMC International Medicine. He is an executive vice chair for Department of Ophthalmology and UPMC Vision Institute. And of course, the professor of ophthalmology, UPMC. One of his greatest contribution to the world of pediatric ophthalmology is he is the founder and the co-director of the World Society of Pediatric Ophthalmology and Strabismus, which is an outstanding organization specifically to teach people around the world. In this slide, you can see two families. He has two families. One is his own family, where he has two sons and a daughter and his lovely wife, Anita. And his second family is children around the world he treats very passionately. On a personal note, he is a great friend. He is an astute clinician and a great observer and a passionate clinician who empathizes with every single patient. If one thing I learn from him every time is how to empathize with the patient and provide the best care for this any patient he takes care. And these are some of the images of his family. And welcome, Ken, for this world's masterclass on pediatric cataract. I also have on the panel Dr. Samar Basak, who is the president of Aios. Dr. Santosh Honor, who just joined, he has some issues with the signal. He is the Honorary General Secretary of Aios, Dr. Manoj Mathur, and myself. And on the panelists, we have Dr. Jagat Ram, who is a refractive surgeon and cornea and cataract surgeon at Grewal Eye Institute, Chandigarh. He was also a former director of PJIMR, Chandigarh. Along with him, we have Dr. Kavita Kalaivani, who is a consultant at Shankar Nethralaya, Chennai, and also Dr. Meenakshi R. She is the Chief Medical Officer and also Chief of Pediatric Ophthalmology and Adult Strabismus Services in the Tirunelveli branch of Aravind Eye Hospital. We are also joined by Dr. Sudarshan Kokar, who is a professor of ophthalmology and in charge of lens clinic at the RP Center, AIMS, New Delhi. And we also have a few case presentations by the budding pediatric ophthalmologist. The first one is Dr. Adeline Lastrado, who was my fellow, now my colleague at Elio Prasad Eye Institute, who is going to talk about clouded beginnings. And Dr. Aishwarya Rathod, she is a senior resident at the RP Center of Ophthalmic Sciences, New Delhi. She's going to present a case on small eye, big surprise, a case of unilateral pediatric cataract. And then Dr. Praveena Shah, who is a fellow in pediatric ophthalmology, Aravind Eye Hospital, Tirunelveli. She's going to throw some light on management of Ectopia lentis with salvaging the bag. And finally, Dr. Abhinaya Palliyappan, who is the consultant at Shankar Nethralaya, Chennai. She's going to talk on cataract in childhood glaucoma. Thank you, everyone, for joining today. And we will start with the lecture by Dr. Nishchal, followed by discussion and the case presentation. Over to you, Dr. Nishchal.
Firstly, thank you so much for your kind words. I really do appreciate them. And I think some of them are perhaps over-exaggerated, but definitely appreciated. Now, I hope that you can see my my slides.
Yes.
We got the green. Okay. So, well, firstly, it's a real honor to give this and to be invited. When Dr. Santosh Hanovar wrote to me, I was very, very honored and privileged, and I want to thank you very much. Those of you who've known me for a long time know that there's something that I always say when I speak to or when I'm in India, and that's Mera Juta hai Japani, Sar par Lal Topi Rusi. I've forgotten the words. Fir bhi dil hai Hindustani. So I was born in Africa, but I'm definitely Indian at heart. So I'm going to talk about pediatric cataract. These are my disclosures. None of them are relevant to the talk itself. But I start by saying there are many experts in the world. On this panel, there are people who have written much more than I have written about pediatric cataract. What I'm going to give you is my flavor. I think sometimes you listen to a lecture and it's an overview of the literature. This is not what this lecture is. This lecture is my approach to pediatric cataract and why I do the things I do. And as an audience, you can decide what you want to do, having taken on my experience. So the first thing that I find that we don't do very well is we don't talk about morphology of cataracts very well. So what I want to do is go through morphology, etiology, evaluation, intervention, and then rehabilitation is the most important, but for the purposes of this lecture, I won't spend a lot of time on rehabilitation. Safe to say it's useless what we're about to do if you don't rehabilitate the child's vision with glasses, patching appropriately. So in evaluation, I think a history is extremely important. The examination is extremely important. And then the investigations are important. The investigations are important to help with prognosis and to help the child as a whole. And I'm going to show you an algorithm that we've created at Pittsburgh, which I'm happy to share. And I have my email at the end if people want to share it. This was a paper I was involved with very early in my career. Very grateful to David Taylor for involving me when I started at Great Ormond Street. And it's called The Morphology and Natural History of Childhood Cataracts. And This is a schematic that I've just recently done for a chapter in a book. I think it's really important to understand what we mean when we say lamella, what we mean by sutral, supranuclear, cortical. What do we mean when we say lens capsule and nucleus? So this is schematic I'm going to come back to. And I'm also going to now show you the sagittal view. This is more complicated, but much better in explaining things. You have a nuclear cataract. A nuclear cataract is bound by the sutures. So the Y sutures they're the boundary of the nucleus. That's a really important point. And then you have what we call supranuclear cortical, which is this gold one. Lamella, remember, lamella is just like, if you think about an onion, it's one layer of the onion that becomes opaque. And then you've got anterior polar, posterior polar, posterior subcapsular, and you can get anterior subcapsular. And you might be thinking, well, it's a cataract. So what? I'm going to show you that by defining what you're dealing with, we're going to be able to, as we go forward, say, hey, if you've got this type of cataract, this is likely the gene that you're dealing with. And this gene we know is only in the lens. So the chances are the cataract surgery is going to be successful and you're not going to have any other intraocular problems. So let's kick off with this. Here we go. This is this is from the paper that I showed you that I was involved with, and it's from the book. The picture was from courtesy of Jack Kansky. So this is a perinuclear punctate cataract, they call it. And this is the one that I was saying was just supranuclear, right? It's just, if you look very carefully here, I hope you can see my arrow, you can just see that there's a suture just there, and this is outside the suture. So it's not nuclear. That tells you when it occurred, right? You have anterior polar, you've got posterior polar, you've got nuclear, you've got cortical, and you've got sutural. All of these become important. Let's have a look at the central cataracts. The sutures here have a gap before you see the nuclear cataract. So that means it's embryonal. If it's embryonal, the chances are that this occurred in the first few weeks of pregnancy, which means the chances are high that it was infection related. This is what we call fetal. And then here are the sutural cataracts. The lamellar cataracts are really important. You've heard the term oil droplet cataract. That's really just a lamellar cataract. It is not specific for galactosemia. You can see the oil droplet sign in lots of lamellar cataracts. And sometimes when they get this outpouching, they're called cortical riders. Those are not specific for any particular condition. Sometimes in the lamellar cataract, just a wedge will become opaque. Here you've got lots of little areas, but if you have a wedge that becomes opaque, I'm going to show you that that can be very, very important to make a diagnosis in a child who's a high myope. Well, we know about posterior lenticonus. There's a posterior subcapsular. That's a posterior nodular. The posterior nodular are the ones we worry about, especially in adult surgery, because if you try to hydrodissect them, the posterior capsule can rupture and now your lens is going south. So it's important to recognize that little nodule on the posterior capsule. At the bottom, you're seeing a PHPV or persistent fetal vasculature, but we'll talk more about those. You've got the anterior polar. This is a child with aniridia. This is a posterior subcapsular, a child with aniridia. And then you've got anterior and posterior polar in the same child. They are not specific for any particular condition. But by acknowledging where they are, it helps you plan your surgery. You may have heard the term cerulean. Cerulean is just a way of saying blue dot cataract, right? And this is a blue dot cataract. This is integrated intraoperative OCT of a child who has posterior subcapsular and then cortical opacities all the way through the lens. The anatomy here is important, right? Because it's showing you that it is just that outer layer of cortex before the capsule is involved. And then when you see an intumescent cataract, the one that you worry about, Argentinian flag, what I have found is that because I have the integrated intraoperative OCT, I can see areas. You see these areas that look dark compared to the rest of it. Those are areas that are filled with fluid. Look at the gap between the capsule and the lens material. If you can enter there with a 27 gauge needle on a syringe and aspirate as you enter, you take the fluid out and you don't get that extension. So these dark areas that you see in intraocular cataracts, that's where you need to enter. The important thing is, intraocular cataracts, I've seen them most commonly in teenagers with diabetes, where they suddenly form. So if you see an intraocular cataract bilateral, make sure that that child is worked up for diabetes. This is called a coralliform cataract. Now, there are some genes that have been associated with coralliform cataracts, but in terms of systemic disease, they're not in themselves significant. This type of cataract is when you see a posterior sutural cataract. So it starts at the suture, but it continues right into a cortical extension. Worry about a metabolic disease. One of those diseases is Fabry's disease. Fabry's disease. So worry about Fabry's disease. And what I did in this boy is I examined the mother. And when I examined the mother, guess what? She had verticillata. So you don't need genes to make, or genetics to make the diagnosis. You need good clinical observation. Here's a child with anterior lenticonus. Of course, you have to worry about Alport syndrome. You may have heard the term pulverulent. This is what a pulverulent cataract looks like. In days gone by, it used to be called the Kopok cataract. That was how it was originally described in the Kopok family. And the gene for this is known. All right, we've talked about morphology, and now I'm going to show you why morphology is important. When you think about etiology, I want you to think about the well child with cataracts and then the unwell child with cataracts. And that helps you understand what's going on. Now, this is a busy slide. Don't panic. We're just going to go through this. Look at the etiology. This is the algorithm I was explaining. If you have a unilateral disease eye, most often, it's due to PFV. It can also be due to posterior lenticonus, but normally that child's a bit older, like 7, 8, 9 months, or even in the second year of, after the first year of life. There are less than 2% of unilateral cataracts have a genetic cause, but you definitely want to think about torch. So if I see a child and they've got this nuclear cataract and it's unilateral, I'm going to do torch because that's more likely to have occurred. And then when you have bilateral cataracts in an unwell child, look at how we define unwell: hypotonia, jaundice, or hepatomegaly, seizures. Once you get into that unwell child, you have to think about cardiac, Hallermann strife, microcephaly, fetal rubella, as the commonest perhaps, hydrocephaly, Walker-Warburg, and then very long chain fatty acids where they get terrible seizures. They're very unwell. Then you think about these rare paroxysmal disorders. I guess what I'm saying is, don't do blanket testing. Do targeted testing so that you know what you're looking for. And if the child has multiple organ involvement, then you think about chromosomal anomalies as well. This website, Adam, is really nice. It gives you these pictures to remember, what the different syndromes look like. So in galactosemia, you have a jaundiced child with cataracts and hepatomegaly. And if you're not careful, they'll get brain damage because of the insult, where the child can't process galactose in the unmetabolized milk. Rubella syndrome, microcephaly, heart problem, cataracts. And the eyes tend to be small as well in those children. This is a paper that I wrote, and I'm only showing it to you because in that paper, we use this picture. If you're going to examine the parents, the biological parents, you've got to do it dilated. In the undilated mother, it looked like she had nothing. But once you dilated her, she had partial lamellar cataract. And so we knew that the child had an inherited form of cataract and that the lamellar cataracts were not due to a metabolic disorder. This is a great paper. Always examine the parents with dilation. And if you see a boy with bilateral cataracts who has hypotonia, then and the mother has these punctate changes, think Lowe's syndrome. If the mother has a sutural cataract, then you think of Nance-Horan. This is one of my patients with Lowe's syndrome. You can see what the cataracts look like. The mother had little punctate opacities. And it's X-linked, and it's an oculocerebral renal syndrome, so they get kidney problems. I'm grateful to Dr. Karthikeyan and Dr. Khan for sharing some of their slides with me here. Actually, these are from their papers. The patient at the top right is my patient, Nance-Horan syndrome. The children, they're boys, they get triangular faces, dental anomalies. They have a higher risk of glaucoma. And the mother usually gets sutural cataracts. Let me tell you why this is important. Only recently, in the last 10 days, I got asked to see a child, but the child has not been born yet, in utero. And these were sent to me, and I did a telemedicine with the mother, and the baby, a boy, has bilateral cataracts. Luckily, in my clinic, one of my colleagues had seen the sister of this boy-to-be. The sister's 7 years old. And look, the sister was noted to have sutural cataract. So I said to the mother, I said, do you have congenital cataracts? She said, yeah, I've been told I have congenital cataracts. From that, we were able to deduce that the child is going to have Nance-Horan syndrome. We confirmed that with molecular testing. So knowing the morphology is really important. We know PFV is the commonest cause of unilateral cataract. Remember, there are some forms of PFV that don't necessarily need surgery because the cataract is mild. These children tend to get myopia, so be aware of that and watch them. Monitor for progression for cataract and for glaucoma. I'm just showing you this video. This is a child who has PFV. You can see the plaque. I've taken out the lens. I've done an anterior capsulorhexis. And what I want you to notice is look at how engorged the iris is. Look at the blood vessels. Now, at this moment, you could say, well, the eye looks a good size. I'm going to take the capsule away. I'm going to put an implant in the eye. You could do that. But in my opinion, this is one case where I would be hesitant to put an implant in, because if you've got so many blood vessels that are so leaky and there's so many of them, there's a bigger risk of antemembrane formation. Of course, if there's no chance that this child's going to wear a contact lens or the family can't afford glasses, you would put the implant in, but you would then be much more aggressive about how you might treat them post-operatively with steroids, etc. So we talked about the lamellar cataract, remember? And then I said you can sometimes just have one part of the lamellar cataract that's affected. And this is a wedge cataract. And if you look very carefully, behind the lens, there is an optically empty vitreous and this membrane. This is Stickler syndrome. Why is that important? The chances of retinal detachment are higher in a child who has Stickler syndrome, especially if you're doing a cataract on them. So you've got to be aware of that. All your maneuvers that you do need to take that into account. Okay, so we've talked about evaluation, we've talked about etiology. Does this cataract need surgery? Well, it's obvious here, right? The bilateral white cataracts, this child needs surgery. There's no doubt about it. But when do you operate? In my experience, and when you read the literature, it's become apparent now that you want to do surgery in a dense total cataract by 4 to 6 weeks if it's unilateral. And the reason is that there's this latent or critical period of vision development, but we know from many studies, and this one I'm going to come to later as well, This is by Matafzi et al. I was a co-author on this. We looked at 470 infant eyes. 470 infants in 7 centers. And what we found was that the of glaucoma were higher if you operated under the age of 4 weeks rather than after 4 weeks. So in my practice, unilateral cases, 5 to 7 weeks if they're dense and complete, and bilateral cases, I'll push out to 8 to 10 weeks. All right. If you look at the picture at the top and the picture at the bottom, you might say, well, the picture at the bottom is a much more significant cataract. Actually, it's a cerulean cataract, and centrally, the media is relatively clear. So in that one, the vision was running at 20/40, and we gave him some glasses, and it improved to 20/30. In the vision at the top, the vision was running at 20/20. He's an older child. But when you did glare testing, the vision dropped by 3 lines. So it's really important that if you can do glare testing and you've got a lamellar cataract, please think about the fact that when you're testing them in your office, it's dim. But you want to test them in real life activity, and that's playing outside. So that's really important. A drop 2 lines or more, and I will offer surgery. I tell the parents that we're losing the ability to accommodate, but I'm worried that if this child's trying to cross the road on a bright sunny day, they may not see a bicycle coming at them. So these are the real things that I like to think about in daily living activity. Well, it's not always that easy, right? This child came to me with a unilateral cataract. You can see the red reflex is gone. And I asked mother to bring me old photos. Unfortunately, nowadays, they're all digital. So you don't get that red reflex necessarily anymore. But you can see at 8, so this was at 6 months, he still had a red reflex. And then at about 12 months, it went. So you know this wasn't there at birth. What else can you do if you haven't got the ability to get photos? You can do VEPs. But before I go on to that, all of us would say that this anterior polar cataract is not significant. You're right. The cataract's not significant, but when you see an anterior polar cataract, especially pyramidal, think about what's going on in the cornea. And you can see that this child has significant astigmatism. It's a little irregular, not desperately, but significant astigmatism. If you miss that in a young child, they're going to lose vision because of meridional amblyopia. All right, let's take this unilateral case. 3-month-old baby girl, born at term, no significant medical history, right eye normal examination, left eye abnormal red reflex. What do we do? Well, if we could wait, it would be better, because the older the child, the easier to put an implant in. And I believe putting an implant in a child in an eye is more physiological, and I'll explain why. But if you wait too long, they may develop irreversible amblyopia. So I'm very lucky. I have the access to pattern reversal VEPs and visual electrophysiology. What I want to show you is this. If you look at the left eye, which was the unaffected eye, and compare it to the right eye at 100% contrast to 200 minutes arc, the right eye shows a lack of morphology. If I reduce it to 50% contrast, the left eye, which is the normal eye, begins to look like the right eye. Now, what that tells me is if I think the lens is reducing 50% of the light getting into the eye, then it's the lens that's the problem. Go in and operate. But if I think it's not, if I think the lens is only contributing to 20%, then it's amblyopia that you're picking up. And so what we did was we put tropicamide in, we patched 50% of waking hours. And although when we repeated the VEP, there was an improvement in this eye, the left eye matured much faster and looked much better. So therefore, I went ahead and did surgery, because I knew I didn't, despite my best conservative efforts, I had no time. So when I decide I'm going to do surgery, I always, before I can decide whether I'm going to put an implant in or not, I like to measure the capsular bag diameter. And the way I do that is I use a linear ultrasound. Linear ultrasound is the ultrasound that your anesthesiologists use to find veins. This is not a UBM, it's a simple linear ultrasound. I have it in the clinic, and you measure equator to equator and you add 1 millimeter. If it's more than 8 millimeters, that bag is big enough to take a 12.5 or 13 millimeter foldable implant. And so that's really very important. I'm getting some messages that I'm trying to. Okay, I guess we'll answer the questions at the end. I'm going to move on. So now that you decide you're going to do surgery, as opposed to an adult who basically gets lens aspiration with an IOL, these are all the different things that you can do in a child. So you're now going to make the decision as to what am I going to do? Well, if the eyes are small, if the child is only 4 weeks old or 5 weeks old, even if it's bilateral, I tend to, if the eyes are small or the capsular bag is small, do a lensectomy. If it's a unilateral case and I'm operating at let's say 5 or 6 weeks, I don't tend to use an implant at that stage. And I do it as simply as possible. So I use a maintainer or bimanual, it doesn't matter. I do a vitrectorexis. I do not want to inject viscoelastic into the eye. Why? Because I believe that the immature trabecular meshwork does not handle getting blocked very well. And if you put viscoelastic in, invariably some of it will affect the trabecular meshwork. So now all I'm doing is I've done my capsulectomy and then I switch my cutter off and I go to the next stage, which is to aspirate all the lens material. Once I've aspirated the lens material, I'll make sure that I do a good anterior capsulectomy and a good posterior capsulectomy, and then an anterior vitrectomy. One of the things I always teach my fellows when they come and work with me is moving your hand around like a wand is not the way to operate in a child's eye. All your maneuvers have to be slow and considered. And then at the end, you've got to make sure that there's no vitreous coming to the wound. I close all my wounds with 10-0 Vicryl. And then I hyperinflate the eye because I want that. I don't want the peripheral iris to block the meshwork in any way. Okay. This is always the spicy masala time, right? Do you place an IOL or do you not place an IOL? If the eyes are too small, they don't tolerate IOLs. And in my experience, that normally is children under the age of 4 months. If they have PHPV and the capsular bag is less than 8 millimeters, or there's or there's lots of those blood vessels, I'm always hesitant. The advantages are that if you're unable to wear your glasses or your contact lenses, you're going to get some focus, right? And it may be protected against glaucoma. Now, I say maybe. I believe it is. And I'm going to show you why in a minute. And there are disadvantages. There's a risk of visual axis opacification. You may need to go back to the OR. Your YAG laser, doing it as an outpatient may be impossible. And you still have to wear glasses. The difference is they're not thick glasses. And they may be more affordable for parents. Now, I'm sure I'm saying some stuff that people are going, oh, how can he say that, the implants can be protective against glaucoma? I am going to show you why it's so important to read the paper and not the abstract. We all know the infant aphakia treatment study. I'm not going to spend a lot of time on it. It said that it was safe to use IOL in young children, that the visual outcomes of contact lenses with IOL are the same at 5 years. Children who had an IOL placement were more likely to require a second operation because of anterior membrane or posterior capsule opacification. The conclusion, and it's interesting, was that IOL should not be fitted in children under the age of 7 months old, and that contact lens correction was better overall. The problem is in the initial conclusion, they failed to emphasize that this recommendation was based on a unilateral disease study. Bilateral disease is different to unilateral disease. How many of you in the audience have seen bilateral PHPV? Not many. Because when you see bilateral PHPV, that child is ill. They either have muscle eye brain disease, Walker-Warburg, they have a problem with their, they could have Norrie's disease. You do not see bilateral PHPV. You do see bilateral isolated cataracts due to isolated gene problems like crystalline gene, GJA3, GJA8, MIP, COL8A1. These are all things that affect the lens, right? The eye is a normal size. So it's really important to not extrapolate IATS data to bilateral disease. Why? Because if you think about it, if a child has a normal eye and a cataract in the other eye, it doesn't matter what you do to the right eye, they're going to rely on the left eye. They're going to have a normal life. But if you have a child who has bilateral cataracts and they don't get implants, and the parents can't afford contact lenses and they can't afford glasses, these children end up in blind schools. So I was asked to write an editorial by the Indian Journal of Ophthalmology. I think it was Santosh Hanavar who asked me, and I wrote Practice Patterns in Pediatric Cataract Management, Time for Real-World Data. Let me explain why. 2 years previously to that, I'd been involved with this amazing paper. And the thing is, it was published in Archives of Ophthalmology, and many of you will not even know about it. We looked at 7 centers. Individual patient data was given to us by those papers written from the 7 centers previously, and we had data on 470 infants. Mean age at surgery, 3 months, median follow-up, 6 years. 80 patients developed glaucoma. Only 2 were pseudophakic. Only 2 were pseudophakic. The authors of eligible studies invited to contribute individual patient data, that's the ones I showed you above, and then we did aggregate data and meta-analysis of published studies that did not contribute, and the data was pooled using random effects. So we used that pool data to compare the individual data, and we came to the same conclusions. And the conclusion was that pseudophakia was protective. Now you might say, why, how? No, that's not possible. Remember that these were retrospective studies with experienced surgeons who chose to put the implant in. In my own hands, let's say I choose to put the implant in 10 infants. My rate of putting that implant in is only 60 to 65% because I find something during surgery that says to me, it's not safe. That's real world data. Why would an implant be protective? This is the thesis of David Walton about pediatric aphakic glaucoma. And he showed that when you co-culture lens epithelial cells with trabecular meshwork cells, their morphology changes to that which is seen in primary open-angle glaucoma, published in 2008 in IOVS. And the idea was that the residual lens epithelial cells secrete interleukin-4, VEGF, after you remove congenital cataract. And this alters trabecular meshwork. Well, if you put an implant in, look what happens, especially if you do optic capture, you trap those lens epithelial cells. They can't get to the meshwork. So we know that there is a logical, if you like, theory as to why it would be protective. Now, it's not going to be protective if your surgical techniques means that you damage the iris, right? That there's a lot of inflammation. That's not going to help. Remember, a randomized controlled trial that was the first one was about the use of streptomycin in tuberculosis. It was a single drug. Surgery is not a single event. Okay, what about the surgery itself? Biometry, I do it awake if I can, under anesthesia. Usually, I use the Hoffa Q and the SRKT. This is my EUA plan, in the OR. I customize my Hoffa Q. So Hoffa Q uses ACD. I customize that for the child so that I know what the anterior chamber depth is. I add a millimeter. And when you do that, look at this. I still have some outliers, but my postoperative predicted target refraction becomes pretty close. So you've got to customize it. So your next question is, what power do you leave them at? This is the graph on the left that I used to use. And then about 15 years ago, I shifted it to the right. So the younger they are, the higher the power, the higher the under correction. And again, I'm willing to share this with people if they want to write to me. So my first case that we told at 8 months follow-up was doing very well. I saw the child recently, is wearing their glasses. Vision is running at 20/50 in either eye, 20/40 with both eyes open, using Cardiff Acuity cards. So here is my 7-point plan. I call it Safe Pediatric Cataract Surgery. And in the next, I think I have about 10 minutes or so, I'm going to go through that. Anesthesia, always paralyze the child. Don't use a suture through the superior rectus, because the younger the child, you're going to transmit tension into the anterior vitreous base. Use an end tidal CO2 as close to 30 as the anesthesia says is safe. Why? Because when you do that, the choroid shrinks, the pressure in the eye drops. Use a general anesthesia, paralyzed. I don't want that eye to move, and I don't want to use traction sutures, and the end tidal CO2 will help you keep that positive pressure down. I do a temporal wound because I do everything from the front. So when I place my IOL, I want to be able to see the leading haptic. I do a corneal incision because the younger the child, the greater the risk of if you do conjunctival disruption, and you have to do glaucoma drainage surgery later, there's going to be a higher rate of failure. And I close all my wounds with tenovicryl. There's lots of ways of doing capsule management, and I'm not here to say one way is better than the other. What I want is something that is consistent, repeatable, and reliable. And no matter what you do, that's got to be something in your hand. In my opinion, radiofrequency diathermy and vitrectorexis don't allow you to manipulate that opening as well if you're putting an implant in. So I prefer a capsulorhexis technique because I want my anterior capsule to be smaller than my optic, because if you don't, you get this lens iris capture. So I describe the 2-incision push-pull rhexis. And in the younger the child, you basically make 2 stabs, you push and you pull, and you get a rhexis. Let me show you. I think this was a 5-month-old child. I'm measuring 4.5 because the lens I use is just 6mm optic. I'm going to talk through this a little bit. So I make 2 stabs with my MVR blade. And then what I do is, you'll see, I push and I pull. Now, because this child is so young, and because the forces are to the center of the lens, and the capsule is elastic, you get a tear forming just there that is a semicircle. Now, the advantage of this technique is that the distance between your 2 stabs is the distance of your opening of your anterior capsule. That's it. There is no other advantage. Now, you may say, if you're experienced, that I can do that. But if you look back, was there a learning curve where you didn't do that, where an individual child ended up with a bigger opening? Because I don't want that for any child. I don't want a child to suffer because of my learning curve. And you'll see here, I'm just finishing off the tear. So they're not always, the semicircles are not perfectly aligned. So you have to just tear it off. Lens aspiration. When I do lens aspiration, I'm just finishing the tear off here. And when, you all know, when you pull to the center to get the tear to turn. And there is the opening. Now, when I do my lens aspiration, I always do it the same no matter what the cataract is. I take the periphery out first, take the nucleus out last. Why? In children, there's a bigger danger of a posterior defect. If you take the nucleus out first, then and vitreous comes forward, now you're trying to aspirate the periphery, and you're tugging on vitreous, that's when retinal detachments occur. So that's my opening. I'm now going to go on. When they're older, you have to do it in steps. So what I do is I've made my two stabs here, and I've enlarged it. And what I'm going to do is I'm going to take one edge and push it to the left. And it's almost like I take it over here. Then I take this one and bring it over here. Now, in the older children, when you finish off the tears, you include the initial tears, the initial stabs, because you don't want a weak point. Because in children, in my experience, over the age of about 2, it can be a weak point. Usually up to the age of 4, you can just do the push-pull like I showed you in the first video. But here, all I'm showing you is that it's all controlled because you're always pushing and pulling center. So the tear's not going out anywhere. And as I come around, I just include that initial tear. And then when I finish this side, I do the same. Again, if you're experienced, this is not for you. This is for people who are starting and want to make sure that their opening is the same size. Even if you want to do the regular Rexus, if you make your 2 stabs, start with one and just use the other one as a guide. It's just to make sure that your anterior opening is smaller than your optic. Okay, that's what you want to end up with. You want to end up with the lens away from the pupil, held back by the capsule. So what about the posterior capsule? In my experience, any child under the age of 5 gets a posterior Rexus and gets an anterior vitrectomy. Any child 5 or over gets a posterior Rexus. And I even do them in 16, 17-year-olds. Because people say YAG laser capsulotomy is easy once they're 8. Look at this child, sent to me because she's 9 years old. Somebody had tried to do the YAG laser capsulotomy 6 times. And the reason why it wasn't opening is that in children, the lens epithelial cells, they grow very aggressively. And it's like lasering into sponge. So no, I don't want to. Why do I want the hassle? I do a posterior Rexus without disturbing the anterior hyaloid face. And I'm going to show you how I do that. It relies on the fact that Berger space is present. And what you do is you make your 2 stabs, as I'm doing here. And then I use viscoelastic to expand that Berger space. And once you expand Berger space, that's the viscoelastic that I'm putting in. And you know you're in Berger space because the viscoelastic is remaining in a bubble. Then you can just push and pull. In my experience, this technique is the best for the posterior capsule because I get all of my fellows, the first Rexus they do with me is a posterior Rexus. And they do it because they're pushing and pulling to the center. And you know, you have this big mental thing when you're learning adult surgery, don't touch the posterior capsule. Don't touch the posterior capsule. But you have to in children if they're going to have a clear visual axis. When I do my anterior vitrectomy, not only do I do it in the center, but I turn the vitrector face down and I go 360 underneath the remnant of the posterior capsule to stop a scaffold forming and to reduce visual axis opacification. And I do it in all children who are under 5. Remember, I was telling you why you want to take out the lens cap, the lens material out peripherally first. Look at this case. Once I took out the lens material the way I told you, look how the vitreous came forward. If I'd taken out the nucleus first, I would have ruptured that and I would have had vitreous all over the place. So the lens removal, phacoaspiration, remove the periphery first. I avoid putting the lens in the sulcus in younger children. There's plenty of evidence that if you do that, the eye stops growing. That's the paper at the bottom. And also that you get an increased risk of glaucoma. Here's a child sent to me for a second opinion with glaucoma, lens in sulcus. The iris root gets pushed forward. So place in the bag. Immediately you take the lens out, the material out. Remember, the posterior capsule gets pushed forward. When you do your rhexis and you inflate, unlike an adult, these leaflets now in children, in young children, they point downwards. If you put a lens in and rotate, the leading haptic is going into the posterior segment. So here is the anterior opening. The posterior opening is bigger than it. I've got about 2 minutes left now, so I apologize for running a little bit over. You put the leading haptic in the bag. You then knock the optic into the bag. Then you place the trailing haptic. You don't rotate. Now, if you do your surgery where you put the implant in, you close the eye, and then you do pars plicata, of course this doesn't apply to you. If you do your surgery where you put the implant in and then go underneath the bag and open up, of course it doesn't apply to you. But for me, it's clean. All the way, I can do a good vitrectomy. I can do a good big rhexis. I'm not hampered by the lens being tilted. So that's why I like to do it this way. And you notice the lens is not rotating. I'm just placing the lens and you're done. Which IOL? I prefer the three-piece. Why? If I'm in the middle of surgery and something happens to the capsule, I have to put it in the sulcus, I have the three-piece. I think Marie-José Tassignon's bag in the lens is excellent. I don't have access to it in the USA, but the idea is that the lens is grooved, so you put the anterior and the posterior capsule into that groove, and of course it captures the lens epithelial cells as it does when you do a posterior optic capture, or even just regularly with the hydrophobic acrylic lenses. And these are pictures kindly lent to me by her. Steroids, I use intracameral steroid. We've published it does not cause the pressure to go up, but what it does do is it reduces the chances of anterior membranes. I will give orbital floor triamcinolone in the younger children, 1 milligram per kilogram. This paper shows that with intracameral DEX, you do not get pressure rises. So my 7-point plan: anesthesia, wound, capsule management, lens aspiration, intraocular aspiration technique, lens type, in the bag, placement of the regular lens if you can, and steroids. I do optic capture, and I'm not going to have time to show you that really. But optic capture is important. That's what you want to end with. And I do it in certain circumstances, but I'm beginning to do it more and more because I think it's a really good way. Remember, just because you're supposed to operate, that doesn't mean that you're blind to what's going on. This child was supposed to have surgery, and I noticed on the table that she had a mucopurulent discharge because of a blocked nasolacrimal duct. I probed her and then waited a week. No, it wasn't a week, 2 weeks, and then did the surgery. So don't just go in saying, I've got to do the surgery. Look, examine before you do it. This is the algorithm. Please email me at initialkk at upmc.edu if you need it. I have to thank all of the team, but especially Liz Connor, Megal Gagrani, Amgad, Richard Hagan's my electrophysiology, but Hannah Skanger, Kelly Trippi are our genetic counselors. And please do come to the World Congress. Thank you very much for allowing me to go over a little bit. I appreciate it. Thank you.
Thank you very much, Ken, for providing that comprehensive approach and telling us that there are much more important things than just surgery when you take care of the pediatric cataract. There are 2 or 3 questions before we go to the case presentation. Just if you have any additional thoughts, Ken. The first question is, what are the riders of lamellar cataract? Why do they are in such configuration? How do they form?
Okay, I don't know why the configuration is that way, but it's thought that when the lamellar cataract goes opaque, there is an adjacent opacification or denaturing of the protein. That's the only reason. That's the only thing that I have ever been explained. Also, when the lamellar cataracts form, with the lens fibers, there is an orientation of the lens fibers, and it's interesting that the orientation is on a radial basis. In other words, the fibers form going radially out, and that's another thought as to why that happens. But I don't know. I don't know if anybody else. Oh, Amanda went. Hi, Amanda. Amanda was my resident many years ago. So I have a whole talk on aniridia cataract. If they get a very dense posterior subcapsular cataract, then I do surgery because that makes a big difference to them. Even though they may have foveal hyperplasia, the scatter that comes from the posterior subcapsular is a real problem. So that's how I decide on operating on them. Yeah, I mean, obviously, and you can get white cataracts as well. And that's I think whoever answered that was Dr. Kavita. I agree with you entirely. Oh, and Dr. Coker is worried about the cricket. Well done, Dr. Coker. I'm glad paying attention.
I want to add on something to your to the writers. We published a hypothesis. If you see the adult cataracts with cuneiform cataracts and the cataract come from the periphery, we published this about 5 years back. We compared the adult cataract with the pediatrics, and so it's an inverse cuneiform which is seen in the cases of pediatric cataract. That's what the riders look like. So you please go and check this paper out. I think I'll send you the link of that, and we published it a long back. And it was, I think, that's the only thing which we could find symmetrical, because spokes coming downwards and spoke going outwards. It's a reverse cuneiform. That's what the hypothesis we gave. I hope you'll check it out. Yeah.
I think somebody asked a question about how to address bilateral congenital cataract and microphthalmos. So in my experience, I have gone to using the smaller gauge vitrectors for those. The problem is I don't know how other people feel, but when I get to 27 gauge, the vitrector is a bit longer. And in these children, I like a little bit of rigidity in my vitrector to be able to manipulate. So I tend to use 25 gauge, but in the microphthalmic ones, you really just have to do a really good clean out. And, sometimes I will also of the pupil, the iris, because what happens in these microphthalmic eyes, they're quite sticky and the pupils can sort of shut down again. So I tell the parents, I'm going to give you an artificial pupil that won't move, but I'm more interested in the function of the vitreous of the eye. And I agree. I mean, they're not implant suitable. Most of these, and their bags are normally very small. Dr. Hanover asked, I had a traumatic cataract in a 4-year-old with a spindle-shaped tear in the anterior capsule that was fibrosed. I chose to put an IOL in the bag. Yeah, I mean, the thing is, each case is unique. We talk about what we do, but you have to customize each case. So this is a technique that I published called the banded technique. And what I do is I do a rhexis. Normally the just fibrosed is eccentric. So I do a rhexis in the rest of the anterior capsule, suck out the lens, do a posterior rhexis if I need to. Then I put the implant in the bag. That little band that you've created between the rupture and the rhexis that you did over 6 months contracts out the way. This has been published in JCRS, so it's called the banded technique. So yeah, it sounds like you did exactly the same thing. Oh, not your questions. You're collecting them from the portal. Sorry, Dr. Hanover. Some questions, if a facility has no phaco machine, is it? So that's a really good point. I have never used a phaco. I've never used a phacoemulsification. Well, at Pittsburgh, I don't have a phacoemulsification machine at Children's, and all the cases I've done since, even in Great Ormond Street, I don't think I used a phacoemulsification probe. So I've always been able to aspirate. Very rarely you'll get a calcified lens, and even with the calcified lens, I'm not sure phacoemulsification is the right way to remove it. I know Dr. Koka's got a comment. Yeah.
Yeah. See, we have started doing a multimodal thing. So we do a UBM in these patients, and we realize if you have the lens which is separated from the capsules, it's condensed in the center. Even if the kid is 2 months or 4 months or 6 months, we go with the phaco with a 2.2, and we just use aspiration of the phaco because tip is bigger and give a very minimum energy. You save so much time and you take it out very easily. So we are going to publish this, that if you have a UBM which can tell you the compression of the cortex in between, and you have a clear zone between the anterior and posterior capsule, and the center part actually gets clubbed. So we are just going to publish it soon, and I'll send you a copy of that. And in those ones, it's better to go with the phaco rather than putting biomanual and spending more time and all these things flying and causing the endothelium to be affected.
I agree with sir. We also do that way. We also use the phaco thing without, not phaco, just irrigation thing.
Of course.
Otherwise, it takes very long time to aspirate.
Absolutely right. And it might just spread and spread, and it spreads the endothelium. And phaco, even if you use a little energy, say 10 or 20, it just sucks in fast and it's quicker. And that's what we're doing for the last 4 or 5 years. No regrets there. Yeah.
Yeah, I think one clarification here, when you say SICS in adult cataract surgery, it's a small incision cataract surgery where they make a scleral tunnel and all. So in pediatric, even with the 2 ports and the main wound, we should be able to do it, whether we use phaco or not. If you don't have phaco, like the question is asked, we don't have a phaco setup. Still, how do you take that dense cataract in 2 or 5% of the cases? Is that we can aspirate everything, and then before implanting, you anyway enlarge the wound. With that, you can take it out through a visco expression. So that's one possibility. We don't have to have a phaco machine in every patient without that. But Ken, you will agree what is most important is a good vitrectomy machine. Without that, we can't do a pediatric cataract surgery.
Absolutely. I mean, very well said. I think the thing is this is what I like about bimanual surgery, small incision bimanual surgery, is that I can protect the endothelium. I think I've just been unlucky in that the patients who are sent to me for second, third, fourth opinions, where a phaco probe has been used and their endothelium is decompensated, and I'm doing an endothelial keratoplasty, just must have been, just bad luck on the surgeon who did it. So I think that irrigation aspiration works. I accept what people are saying, that you're not talking about phaco, you're talking about a bigger gauge. So if somebody gave you a big gauge aspirator, you'd use that as well. So I totally accept that. There's a question about so it says, so the IOL power that so I've just talked about the IOL power. I mean, I use an algorithm which is just basically a graph that the younger the child, the higher the undercorrection. But I think that for children, the smaller the opening to take out the bulk of the cataract, the better for me, because I reduce inflammation. The bigger the wound, I mean, there's a very good paper from the 1990s when we went to phaco, when you compared Ecki with phaco, the only difference was the amount of inflammation because of the size of the wound. So I think this is...
Dr. Jagatram, you have a point to make?
What I want to say that actually it is a phaco aspiration, and what we do, it is not phaco emulsification. Except in exceptional cases, there may be calcified cataract, where you cannot even rub it with the bimanual aspiration. They are exception, but actually it is phaco aspiration. And I also, like Dr. Ken and Dr. Sudarshan Khokar, I also use bimanual aspiration most of the time. Many people use even coaxial. That is one. Another issue is during surgery, almost I think most of the cases, we stain the anterior capsule with trypan blue dye. That is one, because that improves the visibility and precision of our size of the rexis, say 5 millimeter, because it has to be smaller than the optic size. Optic size usually is 6 millimeter. That is another issue. Another is PHPV. I like to cauterize the vascularized membrane or the vessel, as Dr. Ken also showed. I like to cauterize and then make cautery of the vascular membrane and do the posterior continuous curvilinear capsulorhexis in such patient, usually with the cutter, particularly in PHPV.
Yeah.
And regarding implantation of the IOL, probably Dr. can prefer 3-piece IOL. Initially, we used to use 3-piece IOL, but most of the time, at present, majority of our cases, they are single-piece IOL. They are the single-piece hydrophobic acrylic IOL. In cases where we want to capture or do the posterior capture, where haptics are in the capsular bag and optic in the vitreous cavity, there we use 3-piece IOL. So otherwise, I entirely do similar as Dr. Ken or probably Dr. Sudarshan Kokar.
You know, so Dr. Jagadram, I've learned so much from you over the years. So I say this very respectfully. I do not see the point of using one lens for one circumstance and then another lens for another circumstance. I feel that if you train people with the one lens and then they're in the eye, and let's say the anterior capsule ruptures. I know it's not common, but let's say it happens, and they've done a posterior rhexis, they can now use the 3-piece and do an optic capture, no problem. If the posterior capsule ruptures for some reason, and they have the 3-piece in the eye, they can now just put that into the sulcus. So for me, for my fellows, for my training program, I want to teach people what to do, how to use lens for the complicated, unexpected cases so that they don't have to think. They immediately go, okay, I know what to do. So, and this is similarly why, my fellows joke with me because I tell them, I don't know how many of you remember the Karate Kid, but in the Karate Kid, the original one, wax on, wax off, wax on, wax off. The kid gets really upset. He says, "You're making me clean your car." And then the guy goes to attack him, and the kid, without thinking, wax on, wax off, protects himself.
No, I agree, but
when I get you to take out the lens material, you do it so that you need for the difficult cases. So I don't see the logic in doing one lens, and I say this respectfully. We're allowed to disagree, right? We're individuals who have our own intellect. I don't see the logic in using one lens for one case, and then, oh, it's a difficult case, now change the lens. I just don't see it. I don't understand it.
No,
unless it's a question of expense.
That is fine, but what I mean to say that, in my opinion, now at present, I find that single piece IOL is much easy to place in the capsular bag than 3-piece IOL. In the initial phases, I always use 3 pieces IOL.
Fair enough.
I think at the epicenter, we have inventory. So we have a single piece and a 3-piece. So we can, at the drop of this 5 seconds, we get another lens ready. So if any of the rhexis, either anterior or posterior, is compromised in the beginning, it's always a 3-piece lens for us. And if it's not, you go ahead, and we got the lenses, we got the powers, we got the inserters. And most of the phacos, I think I'll go back to the question of phaco machines. I think you have to have a phaco machine which has a cutter, vitrectomy, good cuts, and should have a dithermy, because you don't know where you're going to be needing in the eye. So please don't start your cases just with the SICS and doing the aspiration alone with the cannulas, because you need a high flow inside and then to suck out the fibers. If you do just with the Simcoes, it might not be just total aspiration. So you have more chance of VO formation. You can't do a PCC, you can't do a vitrectomy. So I think my word will be for the people that buy a machine, basic machine phaco, will have a vitrectomy pro with it and a dithermy, and that will complete the thing. And if you can have the lenses in inventory to begin with, 3-piece and a single-piece lens for the same patient, and you can always return one. At the epicenter, we have inventory of all the lenses, so we can actually calculate the power on the table and can have at go. So I think a pediatric cataract surgeon will have to have a par of the lenses. He can't go with one single par in his his kitty. That's it.
Sir, if I may add to it, I
Yeah.
usually use 3-piece acrylic, and even for my fellows, I train like that. But now, what I felt was doing the posterior rexus and placing the posterior rexus. Usually, teach them like place the IOL in the back 3-piece, loading the lens themselves because the sisters may not load it correctly. So I used to teach my fellows to load it themselves so that in any situation they can do it, and do the rexes under the IOL, posterior rexes under the IOL. But now what I am telling them, they are having some difficulty. So now what I do is open sky posterior rexes and putting a single piece IOL in the back, and then finally the vitrectomy, which is much more easier. They are finding it. But anyhow, I taught them the way of loading the 3-piece IOL so that anytime they need it, they can utilize it.
Okay, I think we will go on to the case discussion. We have around 48 minutes. We have 4 cases now. So the first case presenter is Dr. Adeline Lestrado. Can you present your case, Adeline?
Hello.
Yeah, go ahead.
Yeah, okay, thank you. Good evening, all. I would like to thank the organizers for this opportunity, and Dr. Nishchal, that was a fantastic talk and a great discussion. So I will be presenting today on Clouded Beginnings, the story of sugar, oil, and the lens. So we had a 4-month-old male infant who was brought by his parents from Lucknow with a diagnosis of bilateral cataract. I think in 2024 and after Dr. Nishchal's talk, we have learned that we have to do a thorough history taking and evaluation before jumping into the management. So let's see how we proceeded. So it was a preterm child with a birth weight of 2.1 kgs, where the child was sent for retinopathy of prematurity screening, and there he was diagnosed with bilateral congenital cataract. The prenatal history did not suggest of any mother having history of fever with or without rashes, but mother had gestational diabetes mellitus. The postnatal history, the child did not have any neonatal jaundice. There was a 3rd-degree parental consanguinity seen, and there was no similar history in the family. The mother said that the child was photophobic and did not fix well at her face since 2 months. On examination, we see there was no dysmorphic facies. The visual behavior, the child was occasionally fixing at light. And we noted a bilateral total congenital cataract with no history, no strabismus or nystagmus noted. The parental and sibling screening showed that the father had a left anterior subcapsular cataract. The systemic examination was within normal limits. So in our in-house study, we noted that the torch infection was the most common for bilateral as well as unilateral congenital cataracts, and metabolic was the rarest, galactosemia being all the more rare. So the ocular, there was no regurgitation on pressure over the lacrimal sac, and the B scan showed an attached retina with an anechoic vitreous. Blood investigation showed there was a complete blood picture, serum calcium and phosphorus was within normal range, but the torch profile showed that the IgG was raised, but CMV for PCR was negative. The liver function test was deranged. The child was screened for inborn errors of metabolism, and it was negative. The gas chromatography mass spectrometry screening showed that there was increased excretion of galactose and galactitol. The capillary electrophoresis screening showed there was no hemoglobinopathies. So a genetic test, whole exome sequencing was done, which showed an homozygous pathogenic variant for GALK1 gene, which was suggestive of galactosemia type 2 in our proband. So why do we see this cataract in galactosemia? The galactose metabolism pathways are blocked, and the accumulation of galactitol in the aqueous humor and the lens causes the osmotic swelling of the lens and the rupture of the cell membranes and protein denaturation. They say that galactosemia cataracts are reversible, but it is only if it's withdrawn from galactose is withdrawn from food before the rupture of the cell membrane. So the timeline of our patient showed that he was diagnosed with bilateral congenital cataract at 40 days of birth, underwent newborn screening, diagnosed with galactosemia. The diet changed to lactose-free formula feed, presented to us at 3 months of age, and we planned for a sequential lens aspiration with a primary posterior capsulotomy and anterior vitrectomy 1 month later. So this child was genetically confirmed to have Galactosemia type 2, and a sequential pediatric lens aspiration was planned with posterior capsulotomy and anterior vitrectomy with or without IOL under general anesthesia. So the intraoperative biometry showed that the horizontal corneal diameter was greater than was 10.5. However, the axial length did not qualify, and so we deferred the intraocular lens implantation. So let's watch this video of the left eye pediatric lens aspiration, where we stained the capsule with trypan blue. With a cystitome, the first nick was made, and using the pediatric rhexis forceps, by grasping, re-grasping, and invert pull, the anterior capsular rhexis was completed. Using the bimanual irrigation aspiration, we have aspirated the lens matter, a thorough cortical aspiration, and an anterior capsular polish was done. So not all cases goes the way we expect. So there was a challenge when we did the right eye. That is, because of the raised intralenticular pressure, there was an intraoperative meiosis that was noted. So first nick was done, the lens was decompressed, and after that, the anterior capsular rhexis was completed. The tag was then pulled out under the irrigation, and both eye underwent a primary posterior capsulotomy and an anterior vitrectomy and was left aphakic. So post-operative day 1, the child was given topical antibiotics, cycloplegics, as well as topical steroids under taper. And here we see a pediatric perimetry video, that is our in-house innovation, where the child is fixing and following light in all quadrants. Post-operative 1 week after bilateral surgery, the suture removal was done. The intraocular pressure was normal, and the fundus examination showed a normal disc and macula. The child was continued on topical medications. Now, post-operative 1 month, we did a real follow-up. That is, the refraction showed a single vision glasses and contact lenses. The eye pressure was within normal limits. There was good alignment. The child was aphakic with a clear visual axis. The spectacle fit and the contact lens compliance was good. The child was able to fix and follow non-illuminated objects as well at 50 centimeters. And the pediatric perimetry that was repeated showed that the reaction time had improved and the child was fixing and following light in all quadrants. So this is how we follow up all our congenital cataracts, that is post-operative day 1, 1 week, 1 month, 3 monthly for 1 year, and 6 monthly for the next 3 years, and thereafter annually. So the follow-up in galactosemia, apart from normal cataracts, we have to look for any learning disabilities, any cognitive impairment or speech defects, and take up for any occupational therapy if required. And prognosis is generally good in galactokinase deficiency as long as the child has been withdrawn from galactose diet. And the child can be at risk of developing pseudotumor cerebri. So this has to be kept in mind. Thank you. And these are the questions to my panelists. I think most of it is almost answered. But what is your threshold for intraocular lens implantation in infants younger than 6 months of age? And what are the systemic evaluations that are done in a bilateral infantile cataract on a routine basis?
So, can we start with Kavita? Do you want to comment on this case and then we go around the panel?
Sure, Dr. Ramesh. Yes, very nice case presentation and very well managed. Most of the, everything, the protocol, everything is mostly how we will also would have followed this particular situation, where this was an infant with clear, straightforward cataract with galactosemia-like picture, and it was rightfully operated. Lens was deferred because of the axial length. So similarly, so that is my threshold or our threshold is for unilateral cataract, maybe up to 8 months. I can push, but not below 6 months ever. Like I haven't seen or I haven't done any child less than 6 months of age, even if all other criteria is normal, for an intraocular primary implantation in an infant. Otherwise, if it's unilateral, 8 months and above is the criteria that we follow in our institute. And so far, aphakia correction, like another nice thing that you showed is bilateral cataract surgery in a child also. Contact lens is a very good option, and sometimes parents feel it is even more comfortable than forcing a child on high phakic glasses. So contact lens is a very good option even for bilateral cataracts in infants.
So one of the thing in this particular case, I just wanted to bring everybody on the same page. Most of the time, what happens is in galactosemia is a rare thing, but for that child and the parents, it's such an important thing. So we all do the reducing sugar for all bilateral cataract because this child came from a pediatrician where you can see that mass screening, so many tests has been done. We don't have to do everything in every child. As Dr. Nishchal said, tailored approach is very important, but bilateral, once you ruled out the familial and probably torch infection, the simple testing of reducing sugar can help us. And then we can go into whether it's a type 1 galactosemia, type 2 or type 3, because some of them will have a pure cataract as a manifestation. Some of them will have a systemic, that is hepatomegaly, all these things are important. This child, when the child came to us, child is already diagnosed to have. So at this point of time, these protein changes are impossible to reverse after watching for 4 or 5 weeks, and then we had to operate. Probably, I would differ with Dr. Kavita that I would have put an implant in this case if there are other things which are allowing me to implant the lens, and that's what the discussion happened with the parents as well. Any other panelists, and Ken, do you have any comments to make for this case?
No, I mean, I think the case has been handled very well. The one thing to remember is that the type of galactosemia where you get brain damage, the child is always jaundiced. So I would classify this case as galactokinase deficiency rather than galactosemia, because some people get confused. They say, "Oh gosh, you're late on diagnosing it." So no, I think the case is handled very well. Look, the question of implantation is very specific. And when people ask me what's the youngest you've implanted, I hate answering that question, but I will share with the audience this. In 2002, I was at Great Ormond Street. We had a baby that was born prematurely with schizencephaly. The parents abandoned the baby, and the baby was being adopted. The baby developed bilateral cataracts at the age of 33 weeks. And we said we were going to wait till the child was 40 weeks and then we would do lensectomies. And the adoptive parents said that A, they couldn't handle contact lenses, and B, they would not want to adopt the baby because of the complications that they'd read about with contact lenses and glaucoma and all of that. So at the age of 42 weeks, after a conference with legal team for the child, legal team of the hospital, and the adoptive parents, I did bilateral primary implantation. That young man now is developmentally delayed, but his only mode of working is with his eyes, of being able to tell people what he wants. So if you ask me the question, that's 42 weeks, that's very young. But the circumstances should dictate what you do, because the child's needs and the parents' needs are different. So, when people say, I don't implant under the age of 6 months, that's fine. But if I have a mother, as I did recently, who has 7 children, and I know she's not going to turn up to the clinics as regularly, and she's got a 5-month-old with a posterior lenticonus, I'm implanting. So you have to customize it. And equally, you have to build up to that. Everybody on this panel will say, You can't jump in after having done 10 pediatric cataracts to implant an infant. You've got to up a senior member come and do it with you when you do, a 5, 6, 7-month-old.
All right, I think we'll go on with the next case and then we'll come back for some more discussion. Dr. Aishwarya, can you present your case? We can't hear you.
Can you hear me now, sir?
Yeah. Go to the presentation mode. Yeah.
So at the outset, I'd like to thank Professor Coker for giving me this opportunity and Aios as well. I'll be discussing a case of a 14-month-old female child whose mother complained of whitish opacity that was noted in the left eye during the evening hours while feeding the child. There was no history of any trauma, no history of any redness or discharge. There was no significant family history. Sibling screening was done, and she was the second child, and the first child was okay. Parent screening was done, and both the parents did not have any evidence of congenital cataract. There was no significant perinatal history. She was born via a normal vaginal delivery at full term. On examination, the visual acuity was 6/19 at 50 centimeters via Cardiff in the right eye, but the child was not following objects and was resisting the occlusion of the right eye when the child was being examined for the left eye. I'll show you a video where we occluded the right eye with the hand, and you can see that the left eye is not taking fixation. And in fact, the child is trying to resist the occlusion of the right eye with her hands. But when we occluded the left eye, you can see that the child is not resisting and is focusing and fixating on the light. So the fixation was central, steady, and maintained in the right eye, but was not in the left eye. The fundus, the posterior pole was healthy, but we were not able to examine the fundus in the left eye. There was no nystagmus. We did a B-scan ultrasound and found that the vitreous cavity was anechoic. The plan was to do an examination under anesthesia for both eyes, following which we'd go ahead with a left eye lens aspiration, plus or minus PCIL, depending upon the circumstance and the size of the eye, along with an anterior vitrectomy under general anesthesia. After the child was induced, we saw that the white to white corneal diameters were 10 millimeter vertical and 10.5 millimeter horizontal in the right eye, and that were 9.5 and 10 millimeters in the left eye. The IOP was 12 and 10 in the right eye and the left eye, respectively. The keratometry was 44 and 45 in the right eye and 47 and 48 in the left eye, then done with a handheld autorefractometer, and both were steep in the vertical meridian. The contact axial length showed an axial length of 19.7 mm in the right eye and 18.7 mm, 1 millimeter smaller than the right eye in the left eye. The ultrasonic biomicroscopy of the right eye showed a clear lens, no abnormality, well-formed anterior chamber, and a no clear lens in the right eye, as can be seen in the clinical picture as well. When you see the clinical picture of the left eye, you can see a central dense plaque that is present. And as can be seen on the UBM, this was present posteriorly attached to the posterior capsule. Now, when we went ahead with the surgery, you can see that we made 2 stab incisions almost about 180 degrees apart. We go ahead with 3 incisions, but in cases when AC becomes shallow, we do first 2 incisions, put air, a dash of Edry, a dash of dye, trypan blue to stain the capsule and make it less elastic, and then go ahead with the 3rd incision superiorly. Once the OVD has been injected into the eye, you see here that the pupil did not dilate with adrenaline, and then we had to go ahead with viscometriasis. The capsulotomy was used to make a nick, and using the grasp and the regrasp technique with a microvitreoretinal forceps, we went ahead with a rhexis. We used a 5 mm mark on the Zeiss microscope that is available to guide us to the size of the rhexis that can be there. Since 5 mm was larger than the pupil, we went with a slightly larger rhexis as compared to the pupil. A gentle hydrodissection was done because there was a possibility of a posterior capsular defect. You see here, and during bimanual lens aspiration, the central plaque breaks into pieces and is brittle, which brings us back to the discussion that was happening about the phacoemulsification previously. Following which, 360-degree cortical clear cortex was aspirated. Once this was done, you can see a posterior plaque that is present and a vessel that is going here attaching to the posterior plaque. This vessel was in the plane of the posterior capsule. You can see on the UBM that there is a vertically shadow that is present that may be suggestive that there is a posterior fetal vasculature stalk that is present, which is not visualized as of now. We zoomed in to see that the cattle tracking was present, that is, blood was still flowing in this I'm sorry. Yeah, the blood was still flowing in this vessel, and thus we went ahead with the cautery of this vessel. Once this vessel was cauterized, we could see that when we were moving the posterior capsule, the stalk was also moving, as can be visualized here. So there was a thin posterior stalk that was present, which was also diathermized to prevent bleeding from that. We then went ahead with a posterior capsulotomy because this fibrotic plaque was not amenable to a continuous capsular curvilinear rhexis, following which we visualized the fundus using a wide angle and an endo illuminator, and you can see a very thin stalk that is present, probably the reason why it was not visualized on the ultrasound as well. A 3.2 millimeter incision was made and a three-piece IOL was injected into the sulcus. The IOL power was calculated using modified SRK2 formula, and we went ahead with 12% undercorrection according to Coker et al. Suture was taken, OVD was removed, and visco was done. Post-operative day 1, the AC was formed, the IOL was stable, we had a good glow, and the retinoscopy in left eye was +5 and +6. We do tend to prescribe the glasses on the first day itself and patch the eye on the first day itself because it sensitizes the parents for the need and the compliance of the glasses as well as the occlusion. The parents need to be explained that in cases where there is a unilateral cataract like this, the glass may be heavy on one side, so they can either go ahead with a high index glass or a very dense frame so that it can help with balance of the glasses. The sizing is important because if the glasses are large, they can touch the lashes and prevent the child from opening the eye. The glasses need to be maintained in a clean position. And the occlusion was explained for half waking hours of the right eye only. And the parents were advised to make the child play with toys when the patching was there. Just a discussion about persistent fetal vasculature. When the embryonic hyoid vasculature fails to regress normally, that is when we call it a PFV, usually is a sporadic presentation and most commonly presents with leukocoria. In approximately 90% of the cases, it is unilateral and presents with the clinical features of both anterior as well as posterior persistent fetal vasculature, including a PPM, elongated ciliary processes, cataract, and a PFV stalk. Now, the challenge is in management that we need to have a very high index of suspicion, especially in eyes that are small, as we saw here, even when in cases when the posterior segment is anechoic on ultrasound. As Professor Ken Nischel mentioned, it is not necessary that we need to intervene in all the kinds of PFV, and some of them we may observe and follow up. In cases where there is a very shallow AC or a flat AC or the microphthalmia is approximately 15-16 mm, when we know that the prognosis is very poor, we may go ahead with VER, or in cases where we are suspecting a masquerade syndrome, there is no harm in going ahead with imaging to rule out retinoblastoma. Intraoperatively, one must always have suspicion for risk of bleeding and have a cautery or a diathermy ready. Posterior capsular defect is common in these cases and one should be ready for it. The cataracts may not be a normal lens and thus may be difficult to aspirate, and we should have a cutter ready for cutting the cataract, or we may need to make MVR stab incisions and cut it with a microvitreoretinal scissors and a forceps. As we discussed earlier, to put or not put an IOL is always a question. Depending upon the size of the cornea, the other eye status, the size of the axial length of the eye, one can decide lens to put, what lens to put, and how much undercorrection to be done. Post-operatively, the potential of vision may range from the eye going into phthisis to as high as 618, 612, which we have seen in our patients of 15 years follow-up. Amblyopia management is extremely crucial, especially because these eyes have a unilateral cataract, as we saw earlier. Thus, parents need to be counseled regarding amblyopia as one of the major rehabilitative requirements, if not less, for as important as surgery. Complications like glaucoma and VIA are anyway common after pediatric cataracts, but more common in cases of PFP, and one needs to be vigilant during follow-up. Risk of resurgery needs to be explained to the patient because in cases of a visual axis opacification, membranectomy needs to be done. To summarize, correct biometry under examination and anesthesia is important. Always expect bleeding and have a diathermy ready. IOL only if the size allow, and 3-piece preferably in cases when you know that there can be a PCD. Glasses and occlusion are a must for which parental counseling needs to be done. Thank you.
Thank you, Aishwarya, for the nice case and good dosity images. Dr. Jagatram, do you have any comments on this case?
I think she has presented very well, and excellent management already done in this case, because as expected, this was a case of persistent fetal vasculature with posterior capsular plaque, and very nicely, I think, IOL implanted, and your primary posterior capsulotomy done. I will also do the same way. And Doctor, I agree with Dr. Ken in one way that these patients of PHPV, he specifically said they have more inflammation while they are operated. So they have to be given steroid for longer time and more frequency, particularly these PHPV patient or persistent fetal vascular lesion patient.
Yeah, especially when they have this long ciliary processes and also vessels, the membrane. There is one case I still remember. I had to do membranectomy for 3 times. IOL, such a dangerous thing to do there. Dr.
Yeah,
Cocker, very well managed case. Do you have any comments?
Yeah, sure. I'm putting this across this case because earlier we was operating maybe once in a month we used to get PFP. Now in my each OT in a week I'm doing at least 2 PFBs, and I'm getting referred from Russia. I'm all over the world. I don't know. I think I'm becoming the doctor for the PFVs now. So the thing is, I'll go back to the first talk also. When you say the eyes, when you put the implant in the gun, unilateral, in my setup, the contact lenses don't work very well because the patients can't afford. They drop there's a 3.4 lenses will be dropped every year if you follow this patient, and these guys can't afford. Unilateral FAK correction, I don't think it's a good idea. So what do you have? So only thing you have is to try to put the lens in as many cases as possible. So if the axial length is less than 17 and if the white to white corneal diameter is less than 8 millimeters, that's where we don't put the implants at all. We leave them aphakic, and contact lenses or glasses, maybe alternate occlusion. And we have been following these patients for the last maybe 10, 15 years. We realize that when they grow up, we'll put the implant. Every time they come back, we measure, it's the same. And the eyes do not grow anteriorly that much. Let's be very clear on that. And they are very rigid eyes. Secondly, if you want putting a contact lenses, yes, we tried in few patients. And again, the parents might get you first set of contact lenses, maybe the second one. After that, they're gone. And the control of infection and putting the drops, the kind of patients we're getting, we're not very good at contact lenses. Let's be very clear about that. Okay. Now, why do I put an implant? If I can put an implant in a small eye, so what is good for the goose should be good for the gander. So why can't we use it for the bilateral patients who are coming to us? So all my bilateral cases, even if they're 1 month old, if the size of the eye, the anatomy of the eye is good, we go and put the implant. Maximum what will happen, we might have to exchange the lenses when they're about 10, 12 years old. So we just checked the data from last 30 years. We realized the percentage of number of patients which were changing explanting the lenses are very few. So we must have done about maybe in the last 2-3 years, about 10 patients, 10 eyes in which the lenses were explanted and put in again. And all these patients had single piece. So we took them out and put a 3-piece now, and they're all doing fine. So rather than not rehabilitating them, not giving, if they can't use contact lenses and not using FAK glasses, if you have a very thick plus meniscus, if the patient will have a tough time in opening the eyes under the glasses. So that's another problem. So we have given bilateral FAKs also, but my aim always is, that's what I teach my fellows and residents, and they're doing a very great job, is if the anatomy size is good, go for the lens. And if your one rex is intact, go for a 3-piece lens. And if it's a younger kid, do not capture the 3-piece IOL because you might have to exchange, especially the unilateral ones. So on the table, we don't do the captures, but once they come back again to us at the age of 3, 4, 5 years, when we know the eye is already developed and the growth has happened, then in those conditions, we do a 3-piece with a capture, which we don't do in the early phase. And PFB as such, you have to have a diathermy with you, I think. I'm sorry. Because without diathermy, there was a discussion in one of the forums in which they said that they cut all the PFBs without any bleed. I beg to differ with that, and I don't agree, because I normally show example of a patient in which you have a Doppler positive. In fact, yesterday somebody sent me a video of a Doppler positive Russian kid in Delhi. He wanted to do it. I said, don't do it without a diathermy because you'll burn your fingers. Today only we finished a surgery in which Sharia was assisting. There was a small stalk in the front, and at the back it was becoming a big. So it has the disc and the macula both into that. So the retina has not detached fully. So we just remove the lens, we put in an IOL, and we cut with the vitrectomy and let it fall back and show to our retina fellows. They say later on maybe they'll open up that closed funnel and get something out of it. But we are getting so many patients, so you've got to be very careful. As Ken said rightly, pick up the surgical technique depending on the need of the patient and the parents also. So you can't force contact lenses to the person who is a laborer. And even the fake glasses, if they lose one, they won't buy the second or the third one. So, I mean, I think in India, things are different. That's it.
Yeah, I agree on that. Contact lens, more than 95% cannot afford the contact lens and provide the care and maintenance. So with regards to, I think, PFE, we discussed a lot of things. In the interest of time, I think we need to move on. We have 19 minutes exactly.
Sure.
We have 2 more cases. Dr. Praveena, do you want to share your case?
Sir, can you see my slide?
Yeah, go ahead.
Good evening, everyone. I'm Dr. Praveena Shyam from Aravind Eye Hospital, Tirunelveli. I'll be presenting the case on management of ectopia lentis by salvaging the bag. This is a case of a 6-year-old female child who presented to our department with complaints of progressive decrease in vision in both the eyes and a poor scholastic performance is informed by her teacher to her parents. Her uncorrected visual acuity was 4/60 and the best corrected visual acuity was 6/36. And refraction revealed a high myopia with astigmatism in both the eyes. And on slit lamp examination, there was a supranasal subluxation of the crystalline lens. The intraocular pressures and fundus were within normal limits. So in this patient is a refractive error due to ectopia lentis. The axial length of the patient was within normal limits and the myopic shift is well explained by the subluxation of the crystalline lens. But what about the associated high astigmatism? According to the rule of astigmatism in ectopia lentis, the axis should be parallel to the direction of lenticular subluxation. And in our case, where we have a supranasal subluxation, we expect an oblique astigmatism with an axis around 105 to 165 in the right eye and 15 to 75 degrees in the left eye. And the subjective refraction of our patient revealed a -3 cylinder in both the eyes with an axis of at 180 degrees in the right eye and 175 degrees in the left eye. And this was well consistent with the patient's corneal toricity as evidenced by the keratometry values showing a with the rule astigmatism. A systemic assessment of the child was done. The child was of average family and immediate family members were also screened and were found to be normal. And there was no evidence of any systemic associations on the blood test, echocardiogram, or any kind of skeletal abnormalities could not be identified. Hence, a diagnosis of ectopia lentis was made. Now, to think about the management options, it always depends on the degree of subluxation in a case of ectopia lentis. And since in our case, the crystalline lens uncovers more than 25% of the dilated pupillary area, we decided to go ahead with a Sioni ring fixation of the capsular bag with the in-the-bag implantation of a single-piece foldable IOL. So after getting an informed consent from the parents, we decided to go ahead with the surgery. First, a clear corneal incision is made away from the area of subluxation and a rhexis of adequate size is made. The lens material is aspirated and a scleral pocket is constructed midway between the area of subluxation. The posterior edge of the Hoffman pocket is made and a bent 26 gauge needle is passed through the Hoffman pocket into the ciliary sulcus and one end of a double-armed ninoprolene is captured into the barrel of the 26 gauge needle and is retrieved through the Hoffman pocket. The other end is passed through the eyelet of a Sioni ring and here we have used an Oralab Sioni ring, a single eyelet one of 10 mm diameter. And the other end is also retrieved through the Hoffman pocket in a similar fashion. The corneal incision is extended to allow the easy passage of the eyelet and the Sioni is introduced into the capsular bag. And after the introduction, we can see that the eyelet is positioned anterior to the capsular bag. And then the sutures are retrieved through the Hoffman pocket. Adequate capsular bag centration is confirmed. The sutures are tied and they are buried and the knot is buried under the scleral pocket. And then a single piece foldable IOL is placed inside the capsular bag. Visco wash is done and the capsular bag and the IOL centration is confirmed and the corneal wound is sutured. So in this child, we had got excellent post-operative vision of 6/9 best corrected visual acuity at 1 month in both the eyes. And at the final follow-up, and now the child is 8-year-old, doing well in her school. And she had an optimal vision of 6/9 in the right eye and 6/6 parts in the left eye with a myopic astigmatic correction. And ours is actually a case of bilateral ectopia lentis with a large refractive error, which has benefited from clear lens extraction with capsular bag fixation using a Sioni and in the bag IOL implantation. Our case also highlights the effective postoperative visual rehabilitation in a 6-year-old child compared to lensectomy at the prime age of emmetropization, and the advantage of salvaging a capsular bag and maintaining the physical barrier to an anterior vitreous phase is also highlighted. So we have done a similar surgical procedure in 35 eyes of 21 patients, of which 14 cases had underwent bilateral surgery and 7 were unilateral cases. The most common type of subluxation which we came across was a temporal subluxation, followed by a superior and supratemporal subluxation. And all the patients had a median visual acuity, best corrected visual acuity of 6/9 at the last follow-up, with an average duration of follow-up being 24 months and the maximum follow-up period of 53 months. And 33 out of 35 patients had a best corrected visual acuity of 6/18. Now, my questions to the expert panel. Would you prefer implantation of a scleral sutured Sioni ring or a lensectomy in a case of ectopia lentis? And in cases where we are going ahead with a lensectomy, what would be the ideal age for a secondary IOL implantation? Thank you.
Thank you, Dr. Praveena, for that presentation. Maybe some more questions. Dr. Nischal, you want to comment on this case? You're muted. You're muted.
Yeah, I'm a little bit conservative. If I know the cause of the dislocation, so I wasn't clear that we figured out what the cause was. If it's Adam TSL4, then I will consider suturing a lens. But it's not my preferred way forward. In children, because the eye is still growing, especially if they have a fibrillin gene mutation, either Marfan syndrome or just a fibrillin gene mutation without Marfan, I've just seen too many erosions and too many lenses dislocated. I don't do them. They come to me for second opinions. In them, I try to do an iris clip lens. I will start off with a contact lens because I can in the USA, but the iris clip lens with a retro fixation is what I prefer when there's no capsular support. But you know, people report that they're getting good results, which is great. I just worry about the connective tissue disorders.
Yeah, absolutely. I think connective tissue disorders, especially the Marfans and the fibrillin related, has to be ruled out. Dr. Kavita, do you have any comments to make for this particular case?
So, like subluxation, since in children, many of the times it is a progressive condition rather than like in trauma. We do kind of are more conservative towards putting Sioni rings, etc. But the age for this child is luckily 8 years. So if I would have managed this child, probably I would have preferred a lensectomy with an SFIOL. But contact lens is the first choice. I would have still offered contact lens because the astigmatism, though high, was symmetric in both eyes and was around -3. So if the child improves with contact lens for a few years, bilaterally, I would have probably, first option would be that, and followed, if I decide on surgery, would have gone ahead with a lensectomy with a iris claw lens or a scleral fixated lens.
Thank you, Dr. Kavita. Even I would agree. I would have done the same lensectomy in both eyes. Dr. Jagatram, do you have any other opinion for this particular case, or you would have done the same thing?
Actually, I will. I have operated several of such children, and I think Dr. Praveen has done excellent job here in this case. And I will go a step further. Because this child is 6-year-old, more than 6 year, up to 6 year, astigmatism will change. These children invariably have some astigmatism. When she has beautifully placed single piece IOL, I will like to place even toric IOL in this case. So while single piece is good, I think toric will be definitely better. Second thing is to secure, I think, with the two eyelid Sioni ring or two MS segment, so that I think nothing happens even later on.
Thank you, Dr. Jagatraman. Yeah, go ahead.
Can I just give a counter view on that? So it's funny you should say that, Dr. Jagadram. I had a child who came to see me, actually not a child, a 17-year-old, who had had a toric lens placed in the eye at the age of 11. Wasn't a dislocation case. And when she's 17 and she still needs glasses, so she wants to put a contact lens on. So she puts the contact lens on, and now she has lenticular astigmatism from a toric lens, and she hates it. So I had to do a lens exchange. So I understand the logic for doing a toric, but in a 6-year-old, as they get older, if they want to put a contact lens, they're going to get some of the astigmatism corrected by the contact lens, even a soft one. Then you give them lenticular astigmatism. So I think that's something you have to be a little bit careful about, because then they hate it. You know, they put their contact lens on and now they've got the lenticular astigmatism. So just something to worry, just think about. I'm not saying not to do it, but just think about it as a possible problem in the future.
I think we agree with you also, because overall, I think if there is a rotation or if there is something, I think whatever we have done, that will be neutralized by negative this. So I agree with you also that we have to keep in mind that if there is a rotation or if there is some adverse this, that is everything we have to keep in mind. So this is a very positive discussion.
Thank you. I think we'll go to the last case, Dr. Abhinaya. Can you present?
Dr. Ramesh, one comment.
Yeah.
Usually in Marfans, we don't put Sione ring, as they said it's a progressive condition. Only all these cases were simple ectopia lentis.
Yeah.
So we also go for iris fixated IOL or sterile fixated IOL.
Okay.
We're thinking of publishing our series. Not only this, the total one. Yeah.
Makes sense. Abhinaya, you are able to share, or?
Yes, sir. I'm just having a small difficulty.
Okay, just open the PowerPoint.
Yes, sir.
And don't minimize it, and then go to the share. You should be able to.
Ramesh, while we're waiting, there's some questions in the. Oh no, we're ready. Okay, good.
Okay.
Okay. So is my screen visible, sir?
Yeah.
Yeah.
Go ahead.
So, good evening, everyone, and thank you for the opportunity. So, my case presentation would be targeted at a discussion on what do we do for cataract surgery in childhood glaucomas. So, while talking about childhood glaucoma, we have an elaborate classification proposed by the CGRN network. And apart from the highlighted category, all the other categories can have a coexisting cataract in presentation, very rarely. So coming to my case, we had a 6-year-old child who came with his grandfather with complaints of diminution of vision since infancy, which was gradual in onset, progressive, and worsened over the past 1 year. Has associated complaints of that of photophobia and watering from both the eyes. So while going through his old records, his past ocular history suggested that he was already started on anti-glaucoma medication from elsewhere, but he was not very compliant to it. We were not able to elicit the past medical, family, and birth related history. We didn't have the parents with the child when he visited us. So coming to the examination part, his visual acuity was perception of light with inaccurate projection of rays in both the eyes. Coming to the intraocular pressure, it was 10 millimeter of mercury in the right eye, and the eye was soft in the left eye. The pupils were fixed due to a posterior synechiae, and both eyes were having wandering eye movements and was not taking up fixation because of only light perception. Coming to the anterior segment photograph, so this is the external photograph of both the eyes, which shows a ophthalmic presentation with horizontal and vertical corneal diameters of more than 13 mm, and HAPS striae and diffuse corneal haze in both the eyes, with the posterior synechiae in both the eyes, predominantly in the left eye, and total cataracts in both eye with calcified anterior capsule. So we didn't get a view of the posterior segment, so we went ahead with ultrasonography, which suggested a asymmetry in the axial length of both the eyes. The left eye was suggestive of a pre-thysical appearance, and because of the soft eye and the reduced axial length, asymmetry. And the right eye had an axial length of 28 millimeters. The pachymetry was around 450 microns in both the eyes, and the gonioscopy showed multiple iris processes, but the angles were open. There was no gross anterior segment dysgenesis. So we went ahead with the working diagnosis of OU total cataract with a coexisting open angle glaucoma. We were not sure of any inflammatory component or uveitic component before because of the posterior synechiae, and he was not, doesn't give any other systemic complaints or any other signs of old uveitis. Since left eye had a shorter axial length and the pressure was subnormal, we considered it to be pre-thysical, and we suggested for a right eye lens aspiration anterior vitrectomy with or without IOL implantation under extremely guarded visual prognosis. So coming to a short surgical clip, the posterior synechial was done. The anterior capsule was fibrosed. We couldn't get a view, so we had placed iris hoops. The fibrosed anterior capsule was tried to cut with a nick and a curved scissor, followed by lens aspiration. We also noticed a posterior capsular plaque, and which was eventually cut with a vitrector, and we did limited anterior vitrectomy and posterior capsulotomy. So because of the unstable bag, large bag, we proposed to leave the child aphakic. We closed the wounds, and in examination under anesthesia, the right eye disc was pale. So coming to the post-operative course, post-operative day 1 was uneventful, but eventually at post-operative day 2 and 3, he developed 360-degree hemorrhagic choroidals. And after antibiotic cover, systemic consult, and negative culture report, conservative management with topical and oral steroids was started initially for clot lysis. So the plan is to go ahead with serial ultrasounds and choroidal drainage if unsettled. And we had already put him on anti-glaucoma medications and prescribed the FAQ classes with the post-op flash which we had got on the post-operative day 1. So coming to the discussion for childhood glaucoma related cataracts, coexistence of congenital glaucoma with congenital cataracts can occur in conditions like congenital rubella syndrome, PHPV, and Peters anomaly. Some syndromic associations are also there, like Loeys syndrome, Pettau syndrome, and homocystinuria. So there is another possibility where a complicated cataract can develop following a glaucoma surgery, and the well-known secondary glaucoma after pediatric cataract surgery. So there are various literature published on these various aspects, and to concise the following considerations which can be taken into account when it comes to preoperative, intraoperative, and postoperative challenges in such cases. So coming to the preoperative part, the eye is ophthalmic, so IOL calculation, axial length variations, they're all a major drawbacks when it comes to the pre-op planning of such a child, and various literature reports that Haigis, L and Holiday 2 formulas are preferred for longer axial lens. I would request expert opinion on the same. And coming to the intraoperative planning in such intraoperative course in such cases, planning incisions are a big problem, because if there is a combined glaucoma filtration surgery performed and everything, we have to plan the incisions accordingly. Conjunctival trauma should be minimal, as discussed by Dr. Ken Nischel earlier. And due to low scleral rigidity, elastic anterior capsule, and zonular laxity, the capsular access becomes much more difficult. An enlarged capsular bag makes it difficult for an IOL implantation. So the call on IOL to be placed or not, and use primary posterior capsulotomy in the first setting or not, any additional optic capture or CTR comes into role in such cases. Because of high positive vitreous upthrust in these cases, viscosurgical devices should be very strong, and we have to go full on. And coming to the post-operative complications associated and considerations associated with such a child, a rapid myopic shift because of refractive surprise. So how much undercorrection has to be done is also a big question when it comes to these cases. The risk of retinal detachment and glaucoma is much more, and the risk of capsular fibrosis, raised IOP can also cause IOL decentration. And as occurred in this child, suprachoroidal hemorrhage is not a big surprise in such children because of sudden decompression. So even in cataracts without a pre-existing glaucoma, we can develop a glaucoma, obviously due to glaucoma following cataract surgery, or IOP changes due to inflammation. So anything is possible. That is why regular follow-ups are a much important part in counseling the parents when we do the cataract surgery. And we should always tell them that cataract surgery is the first step of the treatment, and we do have a big road ahead. So as far as this case is concerned, the clauses of delayed suprachoroidal hemorrhage could have been possibly because of the megalocornea, Habs-Stry, glaucoma-related problem in this child, aphakia, or long axial length, and vitrectomy performed in this child based on previous literature reported. So I would like to thank Dr. Sumita Agarkar and Dr. Kavita Kalaivani, ma'am, and the team Piyush Quint from SN for this opportunity. And for the expert panel, is there any particular precaution or additional step involved in your way of practice, pre, intra, or post-op for such cases? How much do you undercorrect? And thoughts on customized IOL iris fixated lenses for megalophthalmic eyes, because it has been published, and IOL plus or minus, how do we go about? Thank you for this opportunity.
Thank you, Abhinaya. I'm afraid I think we have crossed the time, but still I would like to end with one comment from all the expert panelists and also from Dr. Nischal. We'll start with probably Dr. Jagatram.
I think this was very well done. This case, I think, not implanted IOL as I saw it. So this was a very wise decision. And it is not very common, particularly in children, because incision is small, to have such situation of suprachoroidal hemorrhage. Whenever it happens, I think very rightly we have to place the suture rapidly and close the incision. That is what I can say.
Dr. Meenakshi?
Wonderful presentations all around. Only thing I would like to say is each case is different, as Dr. Kenichal said. So you should customize for child. We cannot generalize any case and give the treatment options. Thank you for the opportunity.
I think Dr. Sudarshan is not there. Dr. Kavita?
So we wanted this case to be presented here in the presence of such an expert panel, because glaucoma and cataract in pediatric age group, we come across in lots of situations, like she said. This is a very complex situation, but generally, I would like to comment that any child who undergoes cataract surgery, the long-term thing is glaucoma. It's always lurking around the corner, whoever does the surgery at whatever age. So to re-emphasize that EUA for all, we need a preliminary EUA for all patients undergoing cataract surgery to look for angle anomalies, and regular follow-ups if needed, that also in EUA, IOP and axial length monitoring along with IOP checking. All that is important for even a normal appearing cataract. There is no cataract in a child which is really, really normal. So that's the take home I want everyone to take. This is a particularly challenging case, but otherwise. Thank you so much.
Thank you. Thank you. Dr. Nischal, final words, please. You're muted.
So thank you very much for allowing me to be part of this fabulous panel and allowing me to give the lecture. Superb presentations. I would just say this. These are very difficult cases that you've just described. The parameters to play a huge role. Ophthalmic surgeons dealing with children, we really need to speak to anesthesiologists, and they really want a low end titles too. And then the other trick is, although there's a greater risk of failure for the drainage procedure, you can put a viscoelastic into the anterior chamber so that you've hyperinflated the eye and made pressure higher. while you're removing the lens. But difficult case. You did a great job. Well done.
Thank you, Ken. I think 2 hours, 5 minutes still looks small for all the discussion. It looks too less in terms of discussion. We have to stop, unfortunately, here. Thank you so much, Dr. Nischal, for spending the Saturday morning with us. It was really educative for all of us, and I'm sure a lot of people would have watched around the world. It would have been beneficial for them as well, and I am sure it will be there on the YouTube for our physicians and other people to watch it later. I would like to thank our panel, Dr. Jagat, Dr. Kokar, Dr. Meenakshi, and Dr. Kavita Kalaivani, and 4 budding pediatric ophthalmologists, Praveena, Abhinaya, and then Aishwarya and Adeline. Thank you very much. I would like to thank all the leadership of AIOS, specifically Dr. Samar Basak and Dr. Honawar, for providing this platform for the education, which is very important. We need to do it more and more. The education should be more democratic. It should be the part of everyone. And last but not the least, I would like to thank Kripal, who is always there as a support and also complete support team of AIOS. Thank you very much. And I'm really grateful to all of your time. Thank you so much, and good night. Thank you.
Thank you.